Good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center here at the University of Kentucky, I'd like to welcome everyone who's joining us for today's Research in Progress webinar on bridging public health and healthcare. And we're excited to have a great topic for us today, developing public health policy research frameworks with concept mapping. So to give everyone an idea of the flow of our agenda, I'll first be introducing our presenters, who will then give their presentation, and then I will introduce our commentators for today, who will then give their commentaries, and then we will open up the webinar to questions from the audience. Speaking about questions, if you have any questions about the presentation or comments, anytime during the webinar, please feel free to type in your questions in the chat box that you can find at the lower left-hand corner of your screen. So it's my pleasure to introduce to you our presenters for today, starting with Dr. Marjorie MacDonald, who is a professor in the School of Nursing at the University of Victoria in British Columbia, and also teaches in the School of Public Health and Social Policy. Marjorie is co-director of the Research in Public Health Systems and Services Initiative to develop a PHSR agenda for Canada. For the past 6 years, Marjorie held an inaugural Canadian Institutes of Health Research Applied Public Health Research Chair. Her research interests include public health systems renewal, health equity, public health and primary care collaboration, public health human resources planning, and implementation science and public health. Currently, Marjorie co-leads 2 CIHR-funded research programs with Dr. Pauly, one that is exploring implementation of public health systems renewal in BC and Canada, and another examining the public health contribution to promoting health equity. Our other presenter is Dr. Bernadette Pauly, who is an associate professor in the School of Nursing and a scientist in the Center for Addictions Research of British Columbia. Bernie is a member of the Research in Public Health Systems and Services Research Collaborative and co-leads 2 CIHR-funded studies of implementation of public health systems and services and integration of health equity in public health. Bernie is an inaugural University of Victoria Provost Community Engaged Scholar and received national awards for her work in promoting health equity and social justice. So with that, I turn it over to you, Marjorie and Bernadette and Bernie. You have the line.
Thank you, CB. I'm Marjorie MacDonald, and Bernie and I are thrilled to be here talking to all of you today. We are going to do a bit of a tag team approach. We'll shift back and forth with different parts of the presentation. So we'll begin, and if you look at this first slide, you'll notice that I inserted and practice in the title of this presentation, because really concept mapping is very practice oriented, and so the development of practice frameworks as well as research frameworks is important in this. Next slide. So I just want to acknowledge our partners in our program of research. We have many partners that include organizations and individuals from both academic and practice settings. And in some ways, our Research in Public Health Systems and Services program of research is quite similar to the practice-based research networks that you have in the U.S., only we only have one in Canada. And that's part of our aim, is to try and develop that here in our country. I also just would like to acknowledge our funders, and I won't go into who those are, but you can see those on the screen. So for the presentation today, just a quick overview. I'm going to give you a bit of a background on our Research in Public Health Systems and Services initiative. We were formerly called the Core Public Health Functions Research Initiative. We're going to talk about, and really the main focus is methodological innovation for studying complex systems and interventions, and that's an important cross-cutting theme in our entire program of research. We're going to talk a little bit about complex adaptive systems as a lens for our methodology, and then introduce concept mapping as a complexity method, and then get into what this is and provide 2 studies as examples of this method. So I'll just give you a bit of a background. In Canada, in the early 2000s, there were several public health emergencies, and I'm sure many of you in public health will have heard of the SARS epidemic that hit primarily Toronto. We also had a tainted blood scandal and several water contamination events, listeriosis, and several other things that happened. What was recognized in some of these emergencies was there had been a loss of public health infrastructure in Canada. So many people were very concerned that we did not have the infrastructure necessary to deal with future challenges. Many people identified the need to define core functions of public health, as had been done in the U.S., and there was a need recognized to really renew and reform our public health system in this country. And so a number of renewal processes were initiated in many of our provinces across the country. So a bit of background about the Core Public Health Functions Research Initiative, which was our former name. In BC, a core public health functions framework was developed as the centerpiece of public health system renewal. We, as a group of academic researchers and policymakers and practitioners in the province, came together to create an interdisciplinary team to establish and develop the public health systems research agenda in Canada. And this was built around the core public health functions framework in BC, and then later around the new public health standards in Ontario. In 2007, we held a think tank to develop an initial set of priorities. We developed a framework to guide our research and a set of collaboration principles. We've been fortunate to receive about between 13 and 15 research grants from primarily CIHR, but also our Michael Smith Foundation to do this. And all of our initial priorities have now been successfully funded. So in 2014, we held another think tank to renew our agenda, and that's when we renamed ourselves Renewal of Public Health Systems and Services. Now, I know that the term services was added to the public health systems research agenda in the United States. We've kind of reversed them. Instead of public health services and systems, we've chosen to foreground the systems piece in our title. So our goals then are to support public health systems renewal in BC and then more broadly in Canada, and to advance this field of research in our country. I've italicized the next point because that's really the focus we're taking in this presentation. One of our cross-cutting themes is methodological development for studying complex public and population health interventions within complex systems. So I'll not get into the other goals, but that's really where we're starting from in our presentation today. So I'm turning this over now to Bernie, and go ahead, Bernie.
Thanks. Hi, everybody. So you can see here on this slide that the development of our program of research around public health systems and services we brought to it, and I should say Marjorie brought to it, the idea of complex adaptive systems, and that really needed to form our work. And because we were understanding PHSSR research in a way that required us to look at it from a complexity and systems perspective, we also needed to think about research methodology and identifying what we would call methods for studying complexity. So these were methods that we felt were aligned with the concepts of complexity science. And here on this slide outlines some of the 6 key complexity dimensions. And I think I'm just going to highlight a couple of them because I think what's important when we start to illustrate concept mapping is that concept mapping as one type of complexity method really is well aligned with some of these principles, particularly like emergence, because a concept mapping really comes from and starts with a variety of diverse perspectives and moves towards some consensus and understanding of what might need to be done to improve public health systems and services. That's just one example, but all the rest really apply well, and you can see even in that process, it's dynamic, it's adaptive. You don't quite know, it's uncertain how it's going to go, and it's an iterative and interactive process. So here are the methods that we've identified as relevant methods for studying complexity, or our complexity methods, if you like. I'll just point out that in our projects right now, we're using case study design, situational analysis, social network analysis, and concept mapping are probably the four main ones we're using at the moment in our current funded studies. And Wanda, who you're going to hear a commentary from later, actually she is the lead author on a paper on using situational analysis and laying out the methodological complexity for how it fits with complexity. So I'm going to focus in just for a few minutes on what is concept mapping, and it's a participatory mixed method approach. It uses both qualitative and quantitative approaches to really create a visual display and representation of ideas that a group has about that could inform policy, could inform practice, could inform future research. And so often concept mapping is used to provide very concrete policy or practice guidance to public health practitioners and decision makers. It's participatory, as I mentioned, because it engages participants through the process, and as I said, uses qualitative brainstorming, so that kind of getting out all of the ideas, starting with very inductively, and then moves through a process which I'll describe in a couple minutes using quantitative methodologies to construct visual maps. I've already mentioned that, it's often got a very practical purpose, and I think on this slide you can see that it can be used to plan or create a framework for evaluation. It can be used to build theory. It can be used to develop measures, indicators, or scale, assess fidelity of a program model, transfer from program developers to program staff, so that kind of process piece. It's an appropriate research methodologies for working with Indigenous communities because it's grounded in participants and is participatory. Can be used to develop a research agenda or clarify ambiguous and contested concepts. So before we give you a couple of examples, I'm just going to give you a quick overview of the steps in the concept mapping process. And one of the very first steps here is not only selecting your participants, that's very important, but developing the focus prompt. And when we show you our examples, we've got two of them, you'll see how the focus prompt looks really super practical and captures a question that sounds really interesting, but it takes quite a lot of work and really our whole team was involved in developing those focus prompts because it has to be a question one question that captures very succinctly what it is that you want to explore through this process. Then once you have the focus prompt and you've identified your participants, they're then invited to generate statements in response to that prompt using guidelines around brainstorming. Once you've got all of the concepts out there, and often it can be, depending on the size of your sample, could be hundreds of concepts, you need to sort those concepts to remove duplicates, and I always think of it like almost like a constant comparative process or a content analysis process where you're sorting them, and then you're asking people to actually rate them in terms of some dimensions such as importance or feasibility, for example. And then, and Marjorie will show you in more detail how the maps are then created using cluster analysis, multidimensional scaling, cluster analysis, and pattern matching, and then the process, and again, this is participatory, so the maps are interpreted together and can be used for planning and evaluation purposes. So we have 3 concept mapping studies that we've done, 1 related to evidence, 2 related to health equity, and Marjorie is going to share with you in depth the second one, which is around effective strategies for integrating health equity, and then I'll just contrast at the end that with one around practical criteria for health equity tools.
Thanks, Bernie. So I am way behind here. There we go. So the first concept mapping study is called Applying an Equity Lens to Public Health Practice, Concept Mapping to Identify Strategies and Challenges. So the purpose of this study is to understand what public health decision makers and practitioners identify as important to enable them to integrate a health equity lens or health equity into practice and decision making. And I'll just mention that an equity lens was one of the important components in our core public health functions framework in BC and has now been taken up in our guiding framework for public health. So I'll start with the brainstorming process. The prompt that we developed as a team was, equity can be incorporated into public health practice and or decision making by, and then we left that open-ended, and respondents then identified a statement that answered that question. We had 15 people from British Columbia and 45 people from Ontario, those are 2 of our Canadian provinces, who responded to this brainstorming survey, which we did online. It can be done in person, and sometimes that works very well, but with our diverse geography, we did it online. So we had a total of 60 participants. In BC, all of our public health roles, from frontline through to more senior executive roles, participated, and we had 5 of our 6 health authorities participate. In Ontario, all 6 of the health units that were part of our study participated, plus Ministry of Health and Public Health Ontario representatives. So I think we had over 100 statements initially, and by the time we reduced duplicates and synthesized them down, we ended up with 33 statements. So based on our experience in the previous concept mapping exercise, our knowledge user team members requested that members of the research team actually do the sorting, because it is a very it is a long and difficult process, and they felt they didn't have time. So we did have 16 people who did the sorting that included both academics and knowledge users from practice. And the purpose there is to sort these into similar groupings that are unique. Each statement can only go into one group, and no value or priority is assigned to any statements in the sorting phase. Then the next phase is rating, and this again was done online. We sent out the list of 33 statements to our knowledge user partners and asked them to rate this. So 17 people from BC and 51 people from Ontario participated in this for a total of 68. They were asked to rate each statement on the importance and feasibility of those statements using a 5-point Likert scale. So this is a bit technical, but each of the sorts, each person's sorts, is then converted into a matrix and summed across participants, and this provides the input for the multidimensional scaling analysis. We used a program called Ariadne, which is a free open source program produced in the Netherlands. Most people in Canada and the US use concept systems, but it's very expensive, and our budget didn't allow for that for this particular study. I know that Wanda has used concept systems, and we've used it in our other concept mapping study. Then the multidimensional scaling takes the similarity data and represents that as distances in 2-dimensional space entering them into a bivariate plot that's a point map. So I'll just flip to the next slide, and you can see that this is an example of a point map. So each of those 33 statements is represented here. Each has a number, and you can see that some of them are clustered close together, which means they're more likely to have been sorted together by participants. Those that are further away would not have been sorted together. Then cluster analysis, the multidimensional statement map is then entered into cluster analysis, which then partitions those statements into non-overlapping clusters. This cluster arrangement is then superimposed on the point map to produce a cluster point map. And then some of the clusters at that point may be merged if it makes conceptual sense to do that, and then the clusters are named by the participants. So you can see this is our cluster point map, and we had 7 different clusters. And I'm going to just move on to the next because it illustrates those clusters a little bit more clearly. So in order to incorporate equity into public health practice and our decision making, people need to be able to balance the tensions. And the main tension here is a tension between universal public health programs and targeted programs. And that presents a challenge for many of our participants. There needs to be a common, simple message, common language. People need to have the same definition of health equity. It is about driving healthy public policy. There needs to be policies to support the integration of health equity into practice. We need to build capacity in the workforce and in the workplace to be able to integrate equity into practice. We need to establish a culture of equity within the organization, and we need to build a knowledge platform, and finally, we need to honor multiple ways of knowing. So it can't be just one type of research method, one type of data. We need to take community knowledge as well as scientific knowledge. And by putting all of those together, this is how our participants believe that equity can be incorporated into public health practice. I'm just giving an example of one of these. This is cluster 3, driving healthy public policy, and I've included this one because this was the most highly ranked. So you can see that there are 4 statements in that cluster. Then another component of concept mapping is pattern matching, and the purpose here is to examine the ratings of importance and feasibility. It's not necessarily to compare means across these, but pattern matching can be used either for individual items and so you can compare on importance and feasibility for individual items within the clusters, or you can compare the cluster means. Here, our diagram is the cluster means, and you can see that in terms of importance, establishing a culture of equity and driving healthy public policy are the 2 most important, and they really are ranked almost the same. The others are also important. You can see all of them are ranked over 4 or close to 4 out of 5. Interestingly, the 2 most important clusters of strategies were the least feasible, or close to the least feasible. Balancing tensions was also identified as least feasible. The other great thing about pattern matching is that you can compare 2 different subgroups within your sample. So because we had 2 provinces, we wanted to compare British Columbia and Ontario in terms of how each of those provinces viewed the importance and feasibility of those clusters. BC identified cluster 5 as the most important, and cluster 3 as the least feasible. If you look at Ontario's, the ratings are much more closely tied together in terms of importance and less dispersed in terms of feasibility. So Ontario saw those clusters as relatively similar in importance and more similar in feasibility. So this gives us some ideas of what which of those clusters might be most important and most feasible to address in each of our provinces. Then a third type of map here is a go zone, and we can take the ratings and plot them on in a 2x2 table. So we've got feasibility on the left-hand axis, and we've got importance on the bottom axis. And you can see of those 4 points, one is identified as close to 3.5 in feasibility and just below the mean in terms of importance, whereas 3 items are below the mean in terms of feasibility. So participants thought these were important. This was an important cluster, but less feasible. Just to have a quick contrast, and I'm running out of time here, so I want to move quickly. But this cluster, more of the statements were identified as feasible than in the previous one, but as somewhat less important. What's important about this is that you can't necessarily start to take action on those things that are not so feasible. So to get a quick win, you might pick a cluster that's reasonably important but has some strategies that are quite feasible, and that might actually help to build some capacity and to help to create a culture of equity to address it. So in conclusion from this study, there is strong evidence from the literature that says developing healthy public policy is important for reducing health inequities, and our public health practitioners agree that this is important. Yet they are skeptical that this can happen and do not perceive it as feasible. So if practitioners don't see the work as feasible, they may not be inclined to seek out opportunities to work with policymakers on this issue or to advocate for policies. So finding ways to enhance feasibility and doing some work to build capacity and to create a culture of equity within the organization may actually help to enhance feasibility. And then even though there is some discrepancy between importance and feasibility, this study, which is grounded in the experiences of both practitioners and decision makers, does provide some concrete direction about potential actions that are identified as both feasible and important. So action can be taken on these to help promote health equity in public health. These strategies are congruent with the emerging literature on effective action to address health inequities, with the exception that no one really addressed the issue of intersectoral collaboration, which we know from the literature is a very important strategy for addressing health equity. And now I'm going to turn it back to Bernie to talk about the next concept mapping study.
So Marjorie just described to you our first concept mapping study around health equity, which was around the strategies for integrating a health equity lens. We had a second project called the Equity Lens in Public Health Project, where we had a study that was very focused on looking at and developing an inventory of available health equity tools, and then looking at those tools and developing criteria to assess their theoretical and practical utility. So in terms of developing a practical set of guidelines or criteria for assessing health equity tools, we used a concept mapping exercise. And so our objective, or actually our research question, was what's the practical utility of available health equity tools? So the prompt that we used was, to be useful, a health equity tool should. And then again, people were asked to brainstorm in response to that prompt, and generated we had close to 100 statements in that one. And this was a BC project, so our sample was a bit smaller, but we did use exactly the same process that Marjorie described, of going through the brainstorming, the sorting, the rating, and then also going through that same analytic process that resulted in 6 clusters that you can see here. And what's really, I think, important about this is when they described to the criteria, they weren't just describing the criteria for the tool. So for example, they did talk about the tool, but you'll see a purple, like a dark purple called user-friendly, kind of at the bottom of your screen there. In that they were talking about the actual tool itself. But when you look at what's actually in those other 5 clusters, a lot of what they were talking about was the system or the system supports or processes that were needed in order to actually implement a tool as being a critical part of kind of the practical criteria. So what this illustrates, I think, as both examples do, that concept mapping allows you to actually map visually some of that complexity, and in itself is reflecting a complex adaptive system around, in this case, a health equity tool, and to be useful, what should it do? We also had ratings of importance and feasibility in that study, but what was most important in this one was to develop those criteria about how to assess a health equity tool in relation to its practicality. And so based on those 6 clusters that you saw, we developed a set of criteria that can now be used to assess health equity tools. So will the tool contribute to improvements in policy and programs? Will the tool contribute to identification of specific actions to improve health equity? Is there a step in the tool that engages or calls for participation of the community or people affected by health inequity? Is it easy to use and understand? Is it quick to use and short? And is there a clear set of steps that guide the use of the tool? So you could take sort of any tool and say, is this a practical tool? And we also have a set of theoretical criteria, but the concept mapping helped us to do this. So to bring all of this together, concept mapping can obviously be used for a variety of purposes, and we've provided 2 examples for you. One to create insights for decision makers around where they might take action to promote health equity, and then also developing criteria for practical assessment of health equity tools. It uses employees' visual analytics, which is often very useful for sharing the findings with policymakers and practitioners. It's participatory, engages a variety of individuals and groups in the analysis, and I think it really does grapple or allows us to really bring forward some of the complexities in public health systems and services in ways that are useful and provide practical information for improving and enhancing public health systems and services. So thank you very much for the opportunity, and I think now we're over to commentaries.
Thank you, Marjorie. Thank you, Bernie. I'd like to first introduce our commentators before they give their comments, starting with Dr. Wanda Martin, who is an assistant professor at the College of Nursing, the University of Saskatchewan in Saskatoon, Canada. Wanda's research lies within a socio-ecological approach to reducing health inequities brought on through material deprivation and systemic issues related to climate change. This includes areas of community food security, housing quality, and ecosystems approach to health. Wanda's comments will be followed afterwards by comments from Dr. Victoria Lee, who currently serves as Chief Medical Health Officer and Vice President of the Population Health in the Fraser Health Region of British Columbia, Canada. As a Chief Medical Health Officer, Victoria's primary mandate is to prevent disease, protect health, and promote wellness in populations and communities in the Fraser region. She also provides executive leadership and strategic oversight in the areas of population health, prevention of non-communicable diseases, communicable disease prevention and control, environmental health, and licensing of community care facilities, Aboriginal health, South Asian Health Institute, mental health and substance use, and population health surveillance. So with that, I first turn it over to Wanda for her comments.
Great, thank you very much. So I am sitting in Saskatchewan, and which is central Canada. So I've used concept mapping for my dissertation, and I'm using it right now to develop an urban agriculture action plan. So I'm using it with members of the public. So I find it a really interesting and useful method. It's especially useful when you're to guide planning and evaluation of public health interventions because of the opportunities for a great number of members of the public or practitioners to add their ideas. So it's a form of crowdsourcing, which is really helpful. It's especially challenging to have that same number of people who did the brainstorming to actually complete the sorting process. And I think Marjorie mentioned that. And I think that what I'm trying with my newer study is to have small groups do the sorting. So we'll see how that goes. But if a person sits and does it individually, which they can also do on the concept systems online, it can work fairly well, but it can be a bit tedious. You're doing this by yourself. You're sitting at the computer and you're trying to figure out how to use this software and put these statements into piles. So I think doing it in small groups actually adds to the idea of a complexity perspective because there's greater opportunity for emergence and coevolution with the small group brainstorming or like small group work in the sorting process. And it's really important to have, I think, the more practitioners or more of the public doing that than the researchers. It just feels like there would be a truer understanding of what's happening on the ground when you've got the practitioners doing the sorting process. And then that it can also help really generate those that idea of self-organization when the individuals are, the participants are doing that as opposed to the researchers. Also, the method really rests on the strength of the wording of the focused prompt. And this can be really challenging to find a prompting statement that's really clear for a diverse group of people. Yet the strength of the method is in the diversity of people that you have engaged in answering that prompt. So trying to make sure you've got it clear enough to a diverse group of people is really quite challenging. But yeah, we'll see how it goes. Over to you, Victoria.
Thank you for that. So I will start with providing some context first. As Bernie and Marjorie had mentioned, one of the provinces I was involved, for example, in Ontario, public health services are organized and embedded in municipalities. And public health services overall are organized very differently across different jurisdictions. In British Columbia, for example, public health services are embedded in the regional health authorities, and regional health authorities provide health services in the acute settings as well as community settings and provide public health services. So Fraser Health is the second largest health authority in Canada, serving over 1.7 million people in 20 municipalities. Geographically, it's actually not a large region, but we do serve very diverse populations from urban to rural and remote communities, and very culturally diverse, and having one of the largest South Asian populations outside of South Asia, the Indian continent as well. So that's been a very challenging, but also a lot of opportunities exist in providing public health services. And as Bernie had highlighted, British Columbia had gone through what's called core public health services and framework, and the foundation for organizing public health services was quite strong. But as political changes occur and as there are different mandates and goals, that mandate for core public health services and accountability structure changed, and even what core public health services are called changed over time. I think we had about 5 or 6 iterations now. So in comparison, in Ontario, there's public health standards that are actually that public health units are accountable in delivering. So whereas in British Columbia we have a very strong foundation of core public health services, we have relatively weak accountability in terms of delivery of those core public health services by regional health authorities. So having had the opportunity to work with the research team with Bernie and Marjorie's leadership has been quite beneficial on multiple fronts from my perspective. I think one of the biggest strengths has been that knowledge users and decision makers have been involved from the beginning in actually directing and also influencing and defining what our research questions are, as well as having opportunities to provide input in methodology. I think as I review my own internal public health services, we are undergoing a renewal process right now with an extensive review of public health services. And what I find, and we're not unique in BC, but what I find, because we're embedded under health services, is that a lot of our core public health services have been eroded over time at the expense of one-on-one clinical services, and we're providing those services under best practice and best evidence in a very data-driven way, but at the same time, it's not necessarily in a setting where we have the luxury to provide clinical services, one-on-one clinical services, in addition to our public health services. So it's been an interesting process to actually refer to some of the research findings that we've had as well, because when we reflect, and we've had some conversations on this as a research team too, when we reflect on health equity and what we've done quite well from my perspective in Fraser Health and move forward, are the areas where we found in feasibility arm to be much easier or doable. So building knowledge platforms, building capacity in the workforce. We've within Fraser created population health and equity unit, for example, and built tools and knowledge training sessions and skill sessions. And the third area is common messaging, and we've done quite a bit of work in messaging and partnered with academic institutions and engaged with our staff, not just in public health but also in the acute setting. So doing all of those things on top of the feasibility lever has rolled out from our practical sense. But then when we even review our current service level and look at what we've done in health equity, where we would have quite a significant impact, and some of the largest impacts through healthy public policy, those areas, and we've identified us lower on the feasibility side. We're lagging quite far behind from my perspective in some of those areas. So I think in kind of going back to how the research results can be translated into public health practice, it's been valuable as a tool to review our current practice and where we are at, but also have that to refer back to in terms of how do we actually take the lessons learned and the findings from our research and feed it into our renewal process, so that we can actually work on the areas that are that have the greatest population health impact as well. I think one area that I think would be quite valuable from public health practice perspective is to have much more timely cycle of results and even preliminary results that are shared to input into public health practice, and to be able to actually use that and be able to test it out in much more real-time kind of a setting. And I think there's also quite a bit of opportunity with data as well. But I'll leave it there and then provide others to comment and open up for questions.
Thank you, Victoria. Thank you, Wanda, for both the research and practice perspectives. Before I turn it back to Marjorie and Bernie for their reaction to the comments, I'd just like to remind everyone, if you have questions, please type them out in the chat box at the lower left-hand corner of your screen, and hopefully we can get to them with the few minutes that remain in our webinar. So with that, I'd like to first turn it back to you, Marjorie and Bernie, for your comments to the commentaries that were made.
Well, thanks to Wanda and Victoria. We really appreciate their comments. And, I think Wanda was bang on in terms of some of the challenges, and appreciate her leadership in trying to sort out how best to get that complicated and difficult sorting phase done in new ways. So we look forward to hearing the results of her current study. With respect to Victoria's last comment, that is the issue of being nimble and timely with results has been an issue for us from the beginning. First of all, we're trying new methods that we weren't necessarily familiar with. It takes longer to kind of turn those around. I think we're moving forward and can do that better in the future, but it is a real issue. And we need to figure out better ways to do that. Part of what we want to do with developing an agenda, PHSSR agenda for Canada, is to engage other researchers. I mean, we're a small group in BC and Ontario, and there aren't enough of us to be able to do the work to turn those findings around quickly. So some of us are a little older and nearing retirement, and we need to replenish our ranks with more and younger researchers. So that's why it's great that Wanda's moved into a faculty position. But if anybody has ideas about how we can move findings into practice much more quickly, we have tried a few things. Brief, what we call just-in-time reports to the ministry that have been used to inform some of their changes in policy, but we haven't done it well enough.
I think I'd just add two quick things. I really appreciated, Wanda, your linking of concept mapping to the principles of complex adaptive systems, because I think that is a really important piece, and the importance of the diversity of people that we can engage using that kind of methodology that really reflects some of the complexity. And like you, I've been thinking about using it with public as well, and particularly public who are impacted by health inequities and who may not necessarily have ways of participating. For example, we've got a national housing consultation going on right now, but you could sort of think about how concept mapping might be used with people that are experiencing homelessness, for example, and I could envision would work really well. Love your idea of focus groups. And then just my other comment, and I really appreciate so much of what you said, Victoria, and what I really took from that and pulled out was also that the research can provide kind of this signpost, sometimes the level of intensiveness that goes into the research. I think it's really important that we don't lose sight of the fact that these can be signposts for practitioners, and it would be fascinating to me to think about, asking this or repeating the concept mapping study that we did to see how it shifted. I hadn't actually thought about using it in that kind of time series ways, but your comments really made me think about that, and also relates to how we continue to make information timely. So thank you for, again, for providing those really, I think, insightful commentaries.
Thank you, Marjorie. Thank you, Bernie. And now we open the webinar to questions from the audience, and I think we have time for maybe 2 or 3 questions, which I'll get to. I'd like to start off by first saying it's an amazing way to, I think, present research results to the practice community, particularly for those decision makers and policymakers, because you provide a visual way of presenting it. So I just want to bring up 2 slides that I really liked, and that was showing first, from one of your studies about visually showing how the the clusters relate to each other in terms of their importance and feasibility, and then mapping it in this slide in terms of showing the balance between feasibility and importance. So would these two slides be sort of the visual way that you would present it to policymakers, for example, or decision makers? Because I think they're great for decision making as decision making tools or decision making aids.
Yes, that's exactly what you could present. I mean, you could present the series of maps from, the point maps, the cluster map, and then the ladder graphs or pattern matching graphs, because that, those are visual. And many of our other methods are also very visual, and it does help to engage people. The other thing that we do is, we would present the original statements and the cluster and where they fit in the clusters, and have people actually name the clusters. So how they get named, it needs to be something that's meaningful and relevant to the people who might be using that. And then the cluster map illustrates those titles to people, and they're catchy, and you can almost imagine what might be the statements within those thematic clusters. So yeah, these are the maps that would be presented.
So would there be, for example, as you interact with, let's say, the ministry, the health ministry, would you be having some type of composite measure so that they can see, empirically, let's say, for each of the sort of policy alternatives or actions or options, how they, in terms of balancing between feasibility and importance, would they be able to, in the future, rate those? I mean, is that sort of the maybe future intention of it if you were to present it to policymakers or decision makers?
Well, yes, that's the short answer. The thing about our team is that we have those ministry policymakers and decision makers from the health authorities, as well as practitioners on the team, and so they're part of the team that does the interpretation of those maps. And then they can take those forward in their organization because they understand the content and use them for their own purposes. So it isn't necessarily us that does that. And we've had some of our team members actually take some of that back to present in their own organizations. So they take ownership of it and then use it as they see fit.
Okay. We have a question from Patrick Lenihan and also a comment. He says, how did you generate interaction among participants in an online format? He observes it seems like more like a Delphi process than standard brainstorming. And I guess you can relate to also what Wanda was saying about the challenging when doing the sorting, process of, in generating the statements and the structure statements. So how do you find the balance or challenge or addressing, when it's just a person online individually or as a group in person? So if you feel free to comment or react to those questions.
Well, I'm not sure if there might be a better way within the concept system software, but our challenge, of course, is that we are a very large country, very diverse geography. It's not possible to pull people together. Even within British Columbia, we have 6 health authorities and people who live in the far north. It's very expensive to travel. We don't have the budgets. So an online brainstorming is really the best that we could do under the circumstances. Now, if you get together as a team in a research team meeting, you could have people doing it face-to-face. What we've tried to do is, although we've got that initial brainstorming done online and then the sorting online in the study I presented, you can bring people together for the interpretation, and that's what we did. So they were part of the process of, we would present the results to them. They were there in face-to-face meetings in each of our 2 provinces. So that is a challenge, and in some ways It is sort of like a Delphi, although it doesn't have the repeated phases that a Delphi does. It is one of the limitations. If you're doing it in a local area, you could bring people together, and then it might be much more interactive at that stage.
Are there any additional comments from our commentators too? Feel free to also respond to the questions or comments. I guess one question is, if people would like to learn more about this concept mapping, could they find it on your website, Marjorie, Bernie?
I think we have some PowerPoints on our website, but the William Trochim, Trochim, is really the original developer of the method, and he has written a book called Concept Mapping for Program Planning and Evaluation, or something like that. And that's kind of the handbook for concept mapping. There have been a lot of concept mapping studies published, so you could just Google concept mapping. Now, concept mapping is a generic kind of a title, and you might find some other kinds of concept mapping that were done, but if you Google Trochim, he's published quite a few concept mapping studies, and you can learn more about that there. And I don't know, Wanda, maybe you have identified some resources that might be useful, or Bernie.
Yeah, the other one. If I just can say, Bernie, that the Concept Systems website, like I primarily use Concept Systems, and whereas Marjorie's used this other software, I just find it's really clean and easy, and there's support, and it's expensive, but I've worked it into my budgets. So it's, but they have a ton of resources on there and links to papers that have been published using their system as well. And I mean, it is something that you can adapt if you've got someone that can help you to create software otherwise. I did brainstorming with fluid surveys, and I mean, I engaged all of the gardening groups to do the agriculture study brainstorming. So people were quite eager to give their 2 cents. So that piece was really quite easy. But yeah, there's lots of resources on Concept Systems website.
Thanks, Wanda. So there was just last question from Brittany. What was the name again of the free software used by the first presenters? You said Concept Systems is you have to pay for that software. What was that software again?
It's called Ariadne, Ariadne, and it was developed by a man in the Netherlands called Peter Severens, Severens. The problem is all of the literature is in Dutch. So that makes it difficult to interpret. The other thing is he allowed us to use it if we would share our findings with him, because he's kind of gathering examples of the use of that. I have referred a couple of people to him, and they have obtained the software from him and used it. There may be a newer, updated version. It doesn't produce the really lovely maps that Concept Systems does, and you have to use other software. Like we used SPSS to just generate the means and standard deviations on the rating scores, and then we plotted them into ladder graphs ourselves, whereas Concept Systems does all of that for you. So, the advantage of Concept Systems is it's a complete package. You get a visual product, but you pay more money. Ariadne does the job, but you don't necessarily get the attractive graphs. And in the second project Bernie presented, we did use Concept Systems because we had the budget to be able to do that. In the first, we didn't build that into our budget, unfortunately.
So I guess that speaks about the last question. Patrick said, have you tried the clustering function in Excel as a low-budget approach? Because you noticed he said you use SPSS for clustering. Yeah,
I mean, we haven't done that, but I think that would probably work just as well. I mean, there's probably a number of different ways that you can do it if you've got somebody with some software and statistical savvy.
Okay, that sounds great. So Deborah asked us if there's a program recorded for later review. Yes, I'd like to direct your attention that this webinar, we had a lot of interest in it, so it is available for download from the Systems for Action website. And with that, I'd like to thank again Marjorie and Bernie for their time and presentation, as well as our commentators Wanda and Victoria for your time as well too and your inputs. And we'd like to invite everyone again for our upcoming PHSR webinar this coming July 13th. And if you have any questions, please also visit our website. So with that, we thank our presenters and our commentators, and we thank you for everyone for joining us today. Have a great day.